all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. Today, this is actually our first show for the day. I was not able to take the morning show. So let's start our discussion. What I wanted to discuss was there is a study by Oxford which has shown that they have looked at the data from European database systems and compared the thrombosis or clotting caused after COVID-19 versus after flu versus after messenger RNA vaccines, for example, Moderna or Pfizer, versus adenovirus-based vaccines, for example, Oxford's vaccine or Astra Zeneca vaccine and Johnson & Johnson or Janssen vaccine. The basic gist of the whole discussion seems to be the following, that the incidence of clotting is higher in COVID-19, much higher in COVID-19 compared to general clotting incidence in general population. So that is one point that they're making. And that incidence in COVID-19 patients is 100 times greater than a normal, regular person's chance of becoming, having clotting. Second part is that if somebody becomes vaccinated, then their chance by vaccine is about 10 times greater than the baseline. And of course, then COVID's chance compared to vaccine is 10 times greater than the vaccine. So there is this is the data that they are saying that they have seen, but the presentation has a slight interesting way of presenting it, which is, I think it is important for us to look at. The thrombosis that they have discussed are of three types. So let me start sharing my screen as well so we can look at these things. So starting from here, so these are our gifts of humanity. They're continuing. Thank you very much to the cool beans who are actually supporting these activities. So the Oxford College study is saying that the risk of the blood clots is about 10 times higher in COVID-infected patients than I shouldn't say vaccine-infected, vaccinated people. So here it is, clotting in COVID positive 2 weeks after the diagnosis, 100 times higher than normal regular person who's not vaccinated and who does not have clotting. Compared to vaccine, 8 to 10 times higher. 30% of the COVID clotting victims, so COVID, not vaccine, 30% of the COVID clotting victims are under the age of 30 years. So here they're trying to establish that this can happen to younger people as well with the infection. So don't try to take on infection just to be brave or to avoid vaccines. Then they are talking about the rate of clotting in vaccinated. So let's look at that. Cerebrovascular thrombosis. Cerebrovascular thrombosis means what? That in our head, when the blood reaches there, blood reaches through the carotid arteries that go from inside the neck over here or deeper here. They go all the way up to the brain, then they divide, they provide, the blood supply. Then that blood supply or the blood is accumulated back into big, large veins that are sticking. These are big empty spaces. These are sinuses, we call them, because they're bigger. And they're sticking with the bone. And from there, that blood is then removed. So those big sinuses that are attached to the bones, they can become thrombosed as well, or they can develop clots in them. And that is cerebrovenous thrombosis. So the discussion that they have done is, number one, they have looked at the cerebrovenous thrombosis in various cases. Number two, they have looked at the portal venous thrombosis. And portal venous thrombosis is that, if I just very quickly draw that over here, let's say this is liver. What happens is that when we eat something, when we eat food, all that nutritional things that we have taken, they would enter our GIT first, correct? So this is, let's say, our GIT. Here there is small intestine. This is the large intestine, and then here. So this is the, so what happens is food will enter from the mouth, go to the stomach, then get some, stomach acids would help to digest it. Then that digested, half digested food would enter the small intestine. In the small intestine, majority of the things and the fluids and the nutritions are absorbed. They're broken down into smaller basic pieces, and then they're absorbed from there. And when they're absorbed, they are then brought into the blood. But so let's say this is that blood vessels that are collecting blood from all of these areas. Important thing is this, that the blood from GIT is not allowed to enter the regular bloodstream without first going to the liver. So this, all of these blood vessels, veins that are collecting blood, which is filled with nutritional substances that we have eaten, all of this blood is collected into one big vein, which enters the liver. This vein is called portal vein. This is portal vein. Portal vein takes all of this blood that is coming from these areas and brings it to the liver. Liver's job is to filter out the toxic substances or work on the nutritional substances that are coming in, for example, glucose or other things, and either store them or metabolize them or change them. So liver does a bunch of things on these systems, these substances that are arriving before they can become part of our circulation. So you can think of liver as the guard on the things that are coming from the GIT. So whatever you eat has to be inspected in the liver first. So once the liver has inspected them, it has changed them, detoxified them if necessary, then it would add that to the inferior vena cava, which is another vein, which would finally go and open up in the heart. So let's just very quickly make that. So inferior vena cava and then superior vena cava should be blue in color. These would go and open up in the heart in the right atrium. From there, they'll go to the right ventricle. From there, these would end up in the lungs. From the lungs, oxygenated blood would then go to the left atrium, from there to the left vein, left ventricle, from there to the body. So before the blood can go into the body, it has to be taken care of by the liver. And for that, the blood vessel that brings it here is the portal vein. So portal vein thrombosis is another event that is happening in COVID-19 positive patients, that is happening in vaccinated patients, and they looked at that as well. Now with this, another important thing is that in the European societies database for diseases, so when we get a disease, for example, let's say I have flu, when doctor looks at me and says, well, you got flu, or they tests me and they find out that I have flu, in the database system, in the computers, they would code me with this disease with some number, let's say number 120. And that would mean this is flu. So they would say Mobeen had code 120. Similarly, for portal vein thrombosis, there does not exist a code in European Medicine Agency's database. Instead, the researcher says, we looked for splanchnic vein thrombosis. Splanchnic veins are these veins that are collecting blood from the GIT and bringing it to the portal vein. These veins are splanchnic veins. So if there is thrombosis that is happening in any one of these veins, or more of these veins, or maybe even portal vein is declared as a part of splanchnic system, then the splanchnic vein thrombosis is researched in the database. So now what did they see? They saw three things. They looked for cerebral venous thrombosis events. They looked for portal vein thrombosis events, and they looked for splanchnic vein thrombosis events. With that, they came together, they brought together following data. They said, they looked at 500,000 or more than 500,000 patients of COVID-19 past 2 weeks of the diagnosis, and they found that in them 39 per million thrombosis were occurring. So what that means is that out of every million people infected with COVID, 39 were developing clotting. Again, keep in mind the intent of the researchers. They are trying to prove a couple of things here. Number one, they're trying to prove that, hey, if you got the COVID itself, that can cause clotting. And if you're so scared of clotting, that has a 10 times greater risk of clotting. That's one they're saying. 10 times more than the vaccine, 100 times more than regular person. Second thing that they're trying to prove here is that the AstraZeneca's or Oxford's vaccines thrombosis events are almost similar to the thrombotic events with messenger RNA vaccines, that is Moderna or Pfizer. It does sound weird to me, but let's look at the data first so we don't get derailed. So this is the 39 per million is the events if somebody has COVID 2 weeks after. Then messenger RNA vaccine. So if we got the messenger RNA vaccine, for example, I got it, Moderna. Some folks got Pfizer. They took such people, 480,000 or more, and they found that 4.1 number of cases per million. Now compare that to in AstraZeneca first dose, and somehow I did not see the second dose data, but first dose, 5 people per million developed clotting. So if you see here, these kind of look very similar. And this is, of course, high. And then in flu patients, they found 0 per million cerebrovascular thrombosis events. So this line that I'm discussing is for the CVT, cerebrovascular. In this event, cerebrovascular thrombosis, 20% of the patients die. So mortality rate is 20%. So if 100 people got cerebrovascular thrombosis, 20 of them will die. Now, here is a thing that I thought they did not need to do, but they did it. And that is this. I want to show you the, if you see here, this is their, so I have two things. One, I have their actual data and the study paper. And the second one is this little summary of it. In this summary, if you see, they're saying here, CVT, cerebrovascular thrombosis, has been reported to occur in about 5 in a million people after first dose of AstraZeneca vaccine, compared to the mRNA. So check this out. It is very interesting, written in a very interesting way. Compared to the mRNA vaccines, the risk of CVT from COVID-19 is about 10 times greater. So I have Moderna vaccine, and if somebody gets COVID-19, their risk of getting clotting compared to me is 10 times more. Then they say, compared to AstraZeneca Oxford vaccine, the risk of CVT, from COVID-19 is about 8 times higher. So generally, when you look at it, you say, wow, this is 10 times higher, this is 8 times higher, so this looks better. But actually, it is the other way around, right? What they're saying is that AstraZeneca has some more clotting, let's say 5 instead of 4. And because of that, when you divide 39 with 5, you get 8-ish versus 4 with 5, 39 with 4. But when we articulate it in this way, it would kind of give a different kind of an feeling to majority of the readers. They would take away, I think, that, hey, all right, so this is 10 times greater and this is 8 times greater, so this is probably okay. But it is actually the way they put it. So anyways, back here. So this is their takeaway, 10 times and 8 times greater. So what is the summary here for this? Get the vaccine. It would give you less risk of clotting compared to if you wait for the infection itself. Okay, continuing on. The second part, portal venous thrombosis. Thrombosis of the vein that is collecting blood from all of the GIT and bringing it to liver for inspection, detoxification, metabolism, and the first pass, we call it. The first liver gets the first chance to look at what is coming in, and if needed, change it. store it, modify it, do whatever. Liver has a first go at that blood before it becomes part of our circulation. So here, portal venous thrombosis, COVID-19. Now look at these numbers. They are bigger numbers. The portal venous thrombosis, again, I'm not a surgeon, so I cannot probably give a very good idea for how to treat it. But what I have seen is that one can treat that with a bypass or with the tunneling through of that thrombosis. So there are ways to manage that. I think ways to managing cerebral venous thrombosis may not be as um, readily available and sophisticated as portal venous, but I am not a surgeon, so I may just be saying totally wrong. So portal venous thrombosis has a higher number of thrombosis. So if you see here, COVID positive, 436.4 people out of a million. If they get the infection, they get the portal venous thrombosis. The question that I would have asked, and this is not answered there, is this the severe patients? Because COVID have categories, 80% mild and asymptomatic, 20% severe and critical. Out of those, and 5% critical, out of those 3-4% die. So is this COVID thrombosis of portal venous thrombosis in the mild or severe or critical? Who are the folks? I would think that these are the severe and critical cases. So 436.4 per million. Messenger RNA vaccines, Moderna, Pfizer, 44.9 or 45 per million. Astra Zeneca, I actually did not find the data for that. So I'll explain how they then articulated it. So you can, for the time being, forget this. And then flu, 98.4 per million. So now here we are seeing that, hey, COVID is about 10 times larger than AstraZeneca, Moderna and Pfizer. And similarly, some number about 5 times larger than flu. Flu over here causes this thrombosis, but flu does not cause cerebrovascular thrombosis. Now the question is, what is AstraZeneca's own number? And if I go back here in their, you have to do some detective work to kind of figure out what they are trying to say here. So the incidence of portal venous thrombosis in COVID-19 was also higher than that reported for splanchnic thrombosis by the EMA following vaccination with ChAdOx1 or AstraZeneca Oxford vaccine. 53 cases out of 34 million, or 1.6 per million people. So I used the data from this paragraph, which may or may not be right. But if we use this data to say, they're saying EMA, European Medicines Agency, does not have the category of portal venous thrombosis. So because of that, we looked for splanchnic thrombosis, and we came up with 1.6 per million in AstraZeneca vaccine. Then the data becomes that this is 1.6 million, 1.6 per million. This is 44.9 per million, very high. Flu is 98.4 per million, and COVID itself is 436.4 per million. My thinking is that because splanchnic veins are actually, thrombosis is any one of these veins coming from the GIT or stomach, or coming from the small intestine, or coming from the pancreatic or splenic area, or coming from large intestine, they all become portal vein at the end. So maybe if there is a tiny thrombus here or here, they still call that, or they do not call it, or maybe it is less easily findable. Anyways, from what they have written, it seems like this is the number to go here. It does not look right to me. So this is the discussion. They have done a lot of further data processing to say the absolute risk reduction is following and relative risk reduction is following, but this is the summary of it. So I will stop now. The basic idea, once again, is that they are saying, if you are going to decide you don't want to take a vaccine and gonna be exposed to COVID-19, then there are people even lesser than 30 years of age who are becoming, who have clots. And that is 30% of the population who is developing clots from COVID. Second part they're saying is that the COVID is causing lot more clotting than vaccines are causing. Third thing they're saying is AstraZeneca's vaccine is causing slightly more than Moderna and Pfizer. Now, my tiny bit of an opinion, and that is this. Instead of just continuing to say, and here for the first time, you can actually see that they agreed that this is a vaccine associated. That I thought was interesting because I have been hammered a lot by people to say, why do I even say clotting with the vaccine or AstraZeneca together? And I should not do it. And here they actually put that research out and they used a sentence which was very interesting. Here, emerging data suggests that the association reflects a vaccine-induced thrombotic thrombocytopenia. This is Oxford study. They are using this set of terms. When I had used this term to say this is a vaccine-induced possibility, I was sent so much of messages that how dare you say this when there is no such event or no such data to show this, and this is a German guy who's just making this study up, and how did you, meaning there was a lot of pushback. But I want to show us emerging data suggest that the association reflects a vaccine-induced thrombocytopenic thrombotic thrombocytopenia, which, and they are actually referring to same German research that I was. And this term, vaccine-induced thrombotic thrombocytopenia, was actually coined in this study paper by Greenacre. And she said that, I think that instead of calling it idiopathic thrombocytopenic purpura or calling it clotting, we should call it vaccine-induced thrombotic thrombocytopenia. And they have used it here. So at least when I use this, I have now Oxford agreeing with me as well. Now, my opinion, instead of just saying that, hey, we are lesser than COVID, vaccines are better than COVID in clotting, they are more 10 times more than the regular chances, but they are 10 times lesser than the COVID itself. I think the important thing is to say, how do we manage this? That is how the confidence will be built. Not by saying, oh man, it's just better than regular or COVID. That's not going to work. I think the best way to make this work is to say, we understand this is happening. Here is the way to work through this. We would now save everyone who has a propensity of doing this by testing them maybe 5 days later to see if they have developed platelet factor 4 antibodies. If we saw that, even in the outpatient, we would immediately start treating them with blood thinners. We would not let them reach a point of thrombosis and clotting and bleeding and thrombocytopenia. That I think should be, and this is what I've been making noise about from the very first day, that we have to acknowledge, recognize this is happening, it is solvable, we should solve it, we should put a protocol together to say, here is a protocol to solve this. 5th day, anybody who's received this vaccine, now let's say all vaccines are bad, fine. Anybody who got a vaccine, 5th day, please, if you want, go get yourself checked and get your antibodies done, or 7th day. 9 day is the mean time. Give them a chance to do that. Then say, well, if you were positive, we'll give you a Pixaban, or we will give you Rivaroxaban, or we'll give you aspirin. We'll do something, and we would keep this in check. If we need it, we'll give you steroids. If we need it, we'll give you transfusions. We'll give you platelets. We will not let this happen to go down towards death. And they can manage this. This is a manageable situation. So anyways, that is my opinion of this, that instead of just spending all the energy in this area, energy should be spending for how to help it, and then we move forward. So this is the discussion for today. Please like, subscribe, and share. There are 3 links in the description. There is one link to buy me a coffee. If you don't want to use PayPal to support me, you can buy me coffees. There is another link to be a patron, one more link for PayPal as well if you wanted to support me that way. And today there is a special link as well, and that is for Zoom. So if you would like to join me for Zoom in a few minutes, you can do that. I am going to share that link here as well, and it is in the description as well, at the end of the description. So let me put that here too. If you would like to do a Zoom call, we can do that. And let's have those questions. Let me actually answer some questions here, and then we go to Zoom. I'm seeing some questions. For example, Keep Up with MD with Med says, can higher platelet PC percentage be a marker for risk of thrombosis? We did some checkup labs for Astra Zeneca vaccination on my family member, and percent came up higher than normal. No, that should not be. So platelet can be 150 to 450,000. And this actually reminds me to share one more piece of information. Thank you for bringing it up. One more thing that was important, the most important thing is the following: the labs. In the study, they say that we observed that D dimers were increased. Of course, because there is clotting and then dissolution of the clot. When the clot breaks down, it creates D dimers. So they said, if you are going to try to test a person that do they have this kind of a thing going on, look for D dimers. Good. Fibrinogen is reduced. Because fibrinogen is used, it is like a cement for the platelet. So it is used to glue the platelets together. Of course, it is going to be used up. So fibrinogen is reduced. Of course, platelets are reduced. But when that clot is broken down, then the D dimer is increased. And then the rate of thrombocytopenia, that means how rapidly the platelets are going down, reducing in number, that rate is increased. So these are the things. Of course, I have done a complete video about how to manage and approach this situation. That in here, just generally, once again, to repeat that, number one, there are Eliza tests available for platelet factor 4. Then there are antibody tests available separately as well. Then there are platelet activation assays available. However, please, if you are a medicos, a very simple thing, and you know that from HIT as well, heparin-induced therapy, and that is if clinically you suspect that this is thrombosis, then forget about the labs. You put the patient on the treatment while you get the labs. You don't have time to go get the labs. During that time, patient might actually end up with severe results. So you start the treatment right away. Okay, so P. Lee J says, why not try ivermectin after vaccination? Definitely, but ivermectin would not help with the platelet activation. Julie says, but is the blood thinner a lifelong treatment if you have the clot factor? No, it is only in this time. So what happens is when the antibodies are being made, they would be made for some time and then the cells go away. They either are destroyed or they go to sleep, and they say, well, if this happens again, if this thing comes in again, we'll see. So this vaccine-induced platelet factor 4 antibody would disappear after 16, 17 days. So it's a smaller window of time. Hot Chili Bean, Nancy Camp says, King Bean, you're truthful. Don't let the trolls bring you down. Yes, definitely. I am continuing with all of your support. Jenna Douglas is a bit of learn. Okay, very good. What other question before we close and go to Zoom? So Peely says that would taking a week or a month of ivermectin after vaccination prevent this? No. Ivermectin has no mechanism to help with the clotting issue. Instead, aspirin is better, rivaroxaban, apixaban, and then argatroban in the hospital. Al says you're making sense again, Dr. Bean. Thank you very much. I actually think that this is a sort of an unfair thing to do, to start saying, look, this does it too, look, that does it too, look, squirrel. We should provide a solution. For this, we can provide a solution. The reason I am so passionate about it, There was a cool bean who became very angry that when you talk about it, you become so energized that it looks like you like it. And I was just so bothered by that. I become energized because we have a solution. TN says, question, have we seen any increased risk of adverse effects of COVID vaccine in those with connective tissue disorders like Ehlers-Danlos? No. And it does not make sense either for someone with Ehlers-Danlos or let's say collagen 4 issue or collagen breakdown would have any issue from vaccine. Nairi says, hi, cool beans and love Dr. Bean. Thank you very much. Hello back to you. So let's start. Carolyn says squirrel. Yeah, this is equal to showing squirrels. The whole media and everybody is going, well, this percent high, this percent low. Give us a solution. Here is a solution. Here is how we'll approach it. And you are safe now. That is a solution. Denise says, should people with history of clotting take prophylaxis? Yes. 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 And they should talk with their doctor before they get vaccinated. William says, Dr. Bean, do you think these nasal or pill versions of vaccines will have these same issues as the mRNA or adeno vaccines? Very good question. I cannot say it, but I cannot say with data because I don't have the data. But I think that the nasal and the GIT vaccines would be picked up by the immune cells that are around these spaces. These immune cells are more inclined towards moving towards IgA type protection. So they would have local protections with the IgA developed more. So hopefully the barrier function will be sufficient enough to protect us and we don't have to give high doses of vaccines, which may cause those extra things. This is just a conjecture. I may be totally wrong. Eliza says, people who develop CVT or PVT may have tendencies for it, like cirrhosis. They don't take in account those data on their numbers, just give a ballpark. I think they may have looked at that data. I did not go through their tables themselves. They may have seen it. I do not know. But of course, they summarized it. And if you look at their summary, the way they articulated it, I could almost see them thinking that, hey, how do we say that AstraZeneca is more and Moderna is less? And how do we say the Moderna is there as well? So, well, if you do the division, then it's 10 times greater with Moderna and 8 times greater with Moderna, which actually is AstraZeneca more. So I think that they did a PR type of a study as well. I don't want to ding the researchers. I'm sure that they were not biased or they were not influenced. But still, the articulation of it seems weird. So this is the data that we got. I haven't gone through the data myself with the tables. Doug says, if vaccination causes CVT, is TPA indicated? So yes, so absolutely. And not only this, I think that anyone who may be at risk. So for example, we know now women age 48 and below are at a greater risk. For such patients, we should give them much, much more protection in terms of, hey, you can take something in prophylaxis. Hey, you can take this afterward as a prophylaxis. I've talked about the drugs. We can do a test for you, come in on the 5th day or 6th. We would make sure that you don't have those antibodies. And if you have the antibodies, we would work on it right before it becomes an issue in your body and we'll manage it. It is manageable. So Morehouse says treatment protocol is IV immunoglobulin. It's not just the IV immunoglobulin. And Dr. Bean, can you cite your source for TPA? No, I just agreed with Doug that, yeah, that can be done. I did a video in which I talked about all the treatment. IV immunoglobulin is one possibility. Then the apixaban and rivaroxaban is another. But more importantly, most of these patients are in hospital. So gatroban is the first thing to do, and then bring them in the ICU and then let the ICU doctors take care of it. William says, thank you for taking the time that you do each day for us. You give us so much. You're very welcome, William, and I hope that you quickly become better and are fully back to normal. So Morehouse says it can be done for cerebral venous sinus clot that is immune mediated. Which one are you talking about? IV immunoglobulins or something else? IV immunoglobulins have been very, very useful. Outpatient, so for example, if I'm a doctor and I have the patient and I suspect they have this and I feel that their history and I can see them and I know that they would not start bleeding, I would give them rivaroxaban or pixaban or aspirin, something that is available, give them, and then send them for 2 hours of the journey to the hospital where they can get ergatraban and then go into ICU and then decide what to do next. So if hospital is nearby, then the best thing with those symptoms is to end up in the hospital so they can immediately give ergatraban and then take you to ICU. So it really depends what is the chain, what is the situation. So Nancy says, Dr. Bean, have you come across an article in WebMD magazine about the how about we do this? Let's, instead of Zoom, let's do chit chat. Let's come back online and let's do chit chat and have this discussion. I think a larger group of people can join, and then we'll see each other on Monday. I have requested to take Saturdays off. If you are okay with this, I'll take Saturdays off. That actually gives me a chance to wrap my head around what are the latest things that are important to do. Plus, I want to start planning for the diabetes and others. So if Saturday would be useful. So tell me this, should we do a chit chat or should we do a Zoom? Son, always amazed how you anticipate great topics and apply critical thinking to what you share. Thank you very much. And thank you very much for the super chat. Okay, so chit chat. France says, take the weekends. Thank you very much, France. Chat. Okay, so let's do chat. So those who are here, there is one for Zoom, but let's do chit chat here. And then maybe we can do Zoom next time. Thank you very much. So once again, please like, subscribe, and share. And please, if you wanted to support this work, there are 3 links. See them. If whichever link works for you, I would see you in 5 minutes.